So I'm going to have all of our panelists come back on with video and audio. Julie and Stefan. Terrific. And we've had some wonderful questions in the Q&A, and please keep those coming. I do want to start because I think Noel set us up with a really interesting premise that you know, in the vaccine promotion and vaccine acceptance world, we think a lot about educating, convincing, persuading, providing information to, you know, both get parents to vaccinate their kids and adults to get themselves vaccinated. And I think, you know, in your presentation, you know, you sort of de-emphasize those in terms of effectiveness, prioritizing the behavioral interventions, but had this interesting twist at the end that the confidence really is maybe sort of the ecology or the required, you know, precedent to some of the behavior change. And I wanted to give the three other panelists a chance to respond to that, either as a pushback or a reinforcement of where you see what I think is often posed as sort of a tension or a dichotomy. Either we educate and persuade and provide information, or we do these sort of tweaks. So
if you don't mind, I should add one more really important thing. The strongest motivator of vaccination is a provider recommendation. And I mean provider broadly construed, that could include nurses, and it could include other people in the primary care team. So a provider recommendation is particularly powerful, and they really are good at persuading, but it may be that it's the vaccines available, maybe that's how it works, or maybe it's a social process, there's a social contract going on here. So there are places where persuasion may work. We just, for example, with providers, we don't even know which of these processes it's operating through, but thank you very much.
Yeah.
So I agree that confidence and high motivation, it might be there already, and the biggest issues and barriers for vaccination may actually, you know, be at a population level around the practical issues, which might be why system level changes help so much. That's speculative. Another way in which interventions around thinking and feeling may be important is that you can't have a vaccination program with also communicating about it. And if you take away good communication and interventions that focus around thinking and feeling, you do put it at risk. So it's still important as part of that logic model or causal chain through which vaccination programs are successful. And then if you're thinking about the different layers of which vaccination programs need to be effective with the, as Noel said, with the confidence of a politician, of a leader, of a program manager, then that is important as well. I mean, we saw a big difference between our maternal pertussis vaccination rates in Australia and our maternal influenza vaccination rates in Australia. And I think a lot of that was around healthcare provider and hospital motivation to get pregnant women covered for pertussis, because there was a lot of fear and awareness and narrative around the impacts of pertussis in infants, and much less around flu. So, you know, the way people think and feel about vaccination is an important part of the mechanism. Communicating about vaccination is important. It's just that it's a weak intervention on its own for changing coverage.
And I would agree with the more structural interventions, mandates, or even incentives. I think that are both used much more frequently in the US and Australia than in Canada. I think, you know, again, that's not addressing the motivations, the feelings, the communication side of things, but it is sending sort of a clear message at a structural level that this is what we view as important. And it also has the effect, I think, of pushing the individuals who, you know, may find it somewhat inconvenient and not bother with it. Now there's suddenly a bigger reason to seek out vaccination and do that behavior. So I wouldn't want to underestimate those types of factors, but I think also kind of, you know, bringing it back to the altruism point of view, or, you know, doing it for the community. In conversations and some of my research, and this has all been qualitative work, not quantitative, it's hard to quantify these types of things, but in talking with parents who have changed their mind about vaccination, so these were parents who initially did not vaccinate and then were moved towards vaccinating, when they, one of the questions they had, they didn't understand why it mattered. It's my decision, and you will hear this sometimes said by people who have decided not to vaccinate. Why do you care what I do? It's my child. But when they find out that when they understand a bit more about herd immunity and how their decision actually does have an effect on their community, that can move them towards, that can be enough motivation actually to move them towards accepting vaccines. And I think in a lot of our community contexts, we have some religious communities that won't vaccinate in BC where I live, but they're quite willing to do other types of control and containment measures. So it's really important to sort of understand what that context is and work with that community or even that individual if you bring it down to an individual level. There's no one size fits all here.
Stefan, anything to add to that?
Yeah, so I agree with everything that's been said. I think the only caution I would add is that this is really an unprecedented challenge that we're facing here. So we need to be aware that everything we have learned over vaccination and vaccine hesitancy and the factors that lead towards hesitancy and eventually to avoid vaccination potentially may completely shuffle around in the presence of an all-present pandemic. So we may see a whole range of different responses for communities, from demanding the vaccine to get it as fast as possible to get this whole social distancing over and done with, to incredible skepticism in parts of the world where there hasn't been much of an impact, at least in terms of deaths, where people are, well, skeptical of whether they actually need a vaccine. So yeah, just some caution on kind of the relative contribution of those factors may very well be different in this context compared to what we've seen before, but also very different in different.
Yeah, I think different across and different within. Yeah.
Organizations are communicating all the time, even when they're quiet. So it's not like they have a choice in the matter. They can be part of the conversation on social media if they can't, and if they don't, it's to their peril. And in terms of the communications that happen, they can do it well or they can do it poorly. I would say currently the vaccination communication around COVID vaccines is not great. We need to make COVID vaccine communication better, especially when it's coming from policymakers and from agencies. They're doing their best, but they're just so little known, and people keep wanting to fill in the gaps. One thing that worries me greatly is this this framing of the vaccine as a new vaccine because we're doing it quickly. We would be far better off, far better served as a country to identify a single spokesperson and or maybe two spokespeople representing diverse communities, and have those people communicate regularly about what we know about the vaccine, so the vaccine becomes something familiar and that's part of our everyday lives, so that these vaccines, that when they arrive, we have the sense that they are sort of inevitable and they're just simply part of what's been around forever, in the same way that it feels like the pandemic has been around forever.
Well, building on that, I mean, there's so many great questions, but there is a specific one that I think probably resonates with both public health officials and clinicians on the webinar today. If you've got one shot at addressing an audience, one shot, pun intended, addressing an audience to promote an eventual COVID-19 vaccine, and you know there's going to be variation in that group on hesitancy, on prior experience with vaccines, what is the sort of one strategy or message? And we know one size doesn't fit all, but if you've got one shot for a public health campaign or a clinical encounter, how would you all, given your research and what we know about this vaccine and this disease, frame that message, or what strategy would you pull out of the toolkit?
Well, let me make a start on this then.
It's a tough one.
I think I'd go for, well, the biggest possible gain, and as Noel pointed out, the provider recommendation is potentially the biggest factor that we know that influences likelihoods of getting vaccinated. So a strong recommendation from the provider that clearly, in a digestible way, lists the potential, well, benefits and also the risks, with a, well, depending on the frame available, a quick overview of what we know and what we don't yet know about the vaccine. Maybe a good start.
So I might answer in a clinical circumstance, and I'm picking up here on the research that Noel mentioned, also a lot of the work we've done in having vaccination conversations. It would be, let's assume that we have a vaccine or vaccines with good safety and effectiveness profiles. And it's available, and the patient in front of you is eligible for the vaccine. It would be, you're eligible for the COVID-19 vaccine. I think it'd be good if you had it. You know, do you have some questions? And ideally, they would have received some information before that visit, maybe even in the waiting room, if they're able to find a way to screen them. So that there's that presumptive communication, but it leaves some space for the person to ask questions. So you're honouring the need for valid consent as well. And because it's a new vaccine, they may well have questions, but it would be framed around a recommendation. And then if they're very hesitant, then you might take a slightly different pathway, as we've developed in our work in Australia with the sharing knowledge about immunisation guidance.
And Julie has some wonderful materials that she's developed on her website, Sky, I think it's called. Okay, so yeah, the approach we've developed is the announcement approach. There's a website, hpviq.org, that has all the materials. In brief, you announce the child is due. The key thing is to make vaccination like the other services you offer. If you start treating in some different way by saying, well, you know, there's this vaccine, but there's this other one's kind of got a problem. And anyway, well, you don't want to talk about that because we're all uncomfortable now. All of that is the things parents hear and get alert to. So we have to treat vaccination like other medical services they've received in the past. Assume that we're just moving forward with it. And then, as Julie said, if parents have questions, which maybe a third will have questions, some percentage will have questions, everything slows down and meets their needs. What we recommend doing is identifying the main concern that the parent has. So regardless of whatever they throw up immediately, whatever they throw into the conversation, you say, well, okay, what's your main concern? That allows you to get the big bad thing out onto the table and address it. And once that's addressed, our experience is that everything else falls into place.
So lots of questions in the Q&A about specific populations, and I want to throw two of those examples out because I think it'd be interesting to hear from you all about how you think about, you know, tailoring and targeting. So one is there any data on specifically increasing vaccination for specific race ethnic groups? Do we know anything about what works better? And also, what if I'm working with a homeless population? And so there are definitely sort of logistics issues and access issues. How do I craft or tailor a vaccine promotion program for that unique clinical population?
So in the US, we have the Vaccines for Children program that pays for about half of all vaccines for children through age 18. So if a family is homeless or if a family is without a home, a permanent place to live, then they have some options. Typically in the US, it would be going to a local health department. So trying to understand what their ability is to get free and low cost vaccination is really important. So Vaccines for Children provides free vaccine. There is an administration fee up to maybe $17 is the current federal number, but it can't be charged if the family can't afford it. So I would try to understand some of the logistical basic barriers of who has vaccines and what do they cost. For adults, it's somewhat more complicated. I'm not as familiar in that space. As for understanding why different ethnic groups do and don't get vaccines, it is really complicated. So Black adults are less likely to get the flu vaccine than white adults. And however, Black families are more likely to get HPV vaccine, their first dose of HPV vaccine for their children than white families are. So it's not totally clear what the mechanisms for this are as well. There are some explanations for this, but I haven't seen a really telling story here. In the case of HPV vaccine, rates are so low, and honestly, flu vaccine pretty low too. My encouragement is that we just need to get rates up anywhere. The entire US in all groups generally need to get vaccination rates higher. That said, I am concerned with COVID vaccine that there is lower interest among Black people in the vaccine. And I think that is a durable problem. It's very like the seasonal influenza vaccine. That's a durable problem we need to solve right now. I'm hoping maybe there can be programs this fall that try to solve it for flu vaccine as a model for trying to solve it for later COVID vaccines.
Maybe I'll jump in with more of the Canadian experience. And I completely agree with Dr. Brewer that there needs to be a better understanding of sort of the racial inequities in the US. Some of it likely has to do with social determinants of health, but I think there's probably other factors operating in those populations that are not well understood. The example I want to use in Canada, though, is we have sort of similar disparities with our Aboriginal population. And it can't all be explained just by health inequities. We have a very different health system here. And so that doesn't explain all of it. But there's a real history of sort of racism and oppression of this population. And it carries over very strongly into the present day, and also carries over into how these communities view Western medicine, how they view healthcare providers, and the trust that they have in allowing healthcare interventions to come into their communities. And again, it varies by community. So while I'm speaking sort of in very broad general terms, this isn't true for every Aboriginal community in Canada, but you know, where you see coverage rates low, it's the place to start asking questions and to try to understand what's going on. And is it a trust issue? Is it an access issue, or is it something else? And you have to do that on a community basis. There's no magic bullet for dealing with this. You really need to understand the local context.
So I've had the privilege of supervising research degrees of Aboriginal women in Australia, 2 Aboriginal women who have been looking at immunisation, ways of seeing and understanding immunisation in Indigenous communities here. And in fact, we did have a gap between our non-Indigenous and Indigenous immunisation rates. And it's almost reversed for 5-year-olds. And it's through a number of things that we've done in Australia. We've got very good record keeping. We've got a national registry. And if you ensure that there's good data quality around each child, you can then document that they actually are vaccinated. The second is to have culturally appropriate, respectful services instituted through reminder systems. So one success story in a regional part of New South Wales was where 2 Aboriginal health workers were employed to contact every single the parent of a new Aboriginal or Torres Strait Islander baby that was born, get their mobile phone number and give them a call, actually give them an SMS message just before their baby's vaccinations were due. And they closed the gap in that region in immunisation, and it inspired the state government to employ Aboriginal immunisation coordinators in each local health district. And we have closed that gap in New South Wales for Aboriginal immunisation rates, partly through that program and partly through some broad upstream legislative changes that we've had in Australia, which have knocked people into getting their children vaccinated very much on time. So yeah, we've got some success stories here, and it's about cultural respect. It's about understanding the barriers and comprehensively addressing them. And particularly also one more thing is ensuring that it's Aboriginal people also who are employed to support the immunisation programs and be influencers in their communities.
I really like the framing that I heard here, which is that we should think about the context, we should think about the systems that are providing vaccine first. Let's start there before we hang this on people being disinterested or unwilling or not having some kind of capacity we think they ought to have. How have we set up systems that are systematically excluding certain groups of people? One of the areas also in the US that's of particular concern right now is rural versus urban. There do seem to be lower rates on many vaccines in rural areas, and it's unclear what exactly the reason is. It isn't clear to me, for example, whether the problem is in rural areas or that they're just rural areas are typical and some urban areas are just particularly good at giving vaccines. Those are some of the questions that I would have, is what exactly are the systems and how do people access vaccination? So thank you both for those comments.
There was one quick question about homelessness, and I suspect the answer there will be, as the person asking I'm sure would probably know, in ensuring that there's very, very good outreach services with vaccinators who will go to homeless people through normal mechanisms of visiting homeless people and bring vaccines with them as well. So access will be a big issue there.
I'm going to bring up two questions around sort of social norms and misinformation and talking to peers. I also, if the four panelists are able to see the Q&A and you see a hot question that you definitely want to answer, I definitely want to give you guys sort of panelist choice. So that's coming. But let's start with two questions. One around just how do you suggest that lay people talk to others who are vaccine hesitant? What are the best strategies? And specifically where there is government conspiracy theories or, you know, it's misinformation, the myths, the pandemic type videos, what are our strategies for countering that level of disinformation in our infodemic?
Well, we've actually written an article in The Conversation on this called 4 Ways to Talk to Vaccine Skeptics. So Google it. But, you know, there's options. You've got options here. Choose your battles, for one thing. If somebody is dead set against vaccines, any vaccines, you may be wasting your time unless you're looking for a bit of blood sport and entertainment late at night on social media. If their views really matter to you, for example, they're a family member and you need to really sort this out, then having a respectful conversation where you hear them out and you put your position forward is good. Sometimes you'll need to agree to disagree. But if somebody has particularly had an experience with vaccination that's been negative, then those people need listening, and I think, as I answered in one of the questions, it may be helpful to refer them to a specialist service if there's one available where a specialist immunisation clinician can go through their story and look at what happened and help them sort out what happened. And that can often feel for them like there's a bit of, I guess, procedural justice there, if you like. And then there are people who are just a bit hesitant, and it's probably worth investing a bit of time with them and giving, in terms of debunking, the evidence around that says that giving them giving the information that corrects the wrong thinking can actually be effective, more effective than not doing anything at all. But you do have to be careful with that backfire effect when people already have really strong beliefs, and you're going to find some confirmation bias happening there in the way they receive your message.
I'll agree. I mean, take the long view, and that is, there are a couple of versions of that. And one of them is, you're not their doctor. It's not your job. This is someone else's job. Let them do their job and refer them there. If you want to have the conversation, Julie's paper is great. I really like it. I was just waiting for her to go through it.
I send that around all the time to people.
It's fantastic. Another thing is that not everyone you're talking to, at least certainly on social media, is a person. Many of these are bots. So you can just ignore them, block them, just move them out of your life. It's okay to do that. You don't, as Julie was saying, you don't have to engage with everyone on this topic. I will say that my experience has been that I've had a surprisingly large number of folks close to me who are not totally up for vaccines or have very mixed feelings, including a friend who had an adolescent son who was thinking about various vaccines. And we had a conversation over a very sort of light conversation over a period of maybe a year. So I would take small pieces and also be ready for not having all the information you need. There are so many different kinds of concerns. There's so many different kinds of vaccines. You're not going to be an expert. That said, shifting from what Julie said, if you're in a public place and you're speaking on behalf of vaccines and you have to deal with vocal vaccine deniers, the World Health Organization has established, has created an outstanding resource to type vocal vaccine deniers and WHO, and a manual will come up that'll train you how to do this. You have a couple options. You can go point for everything they've said that's wrong and try to debunk it in that way. There's another approach that's equally effective, where you identify their conversational ploys, which is moving the goalposts, denying evidence, and so on. And if you address those conversational ploys that they're using, those conversational moves, that is every bit as effective at shutting them down as trying to go for every single point, which, to be honest, may be hard to pull off. So you're going to have to decide sort of which room you're in. Are you a healthcare provider giving advice? Are you in the room, like Julie was saying, talking to a friend? Or are you speaking to the public and also trying to protect yourself along the way? And if you are, you use that resource from the WHO or Europe.
Those approaches are confusingly called inoculation theory. There's a communication strategy where you give a little weakened dose of the misinformation and sandwich it with the correct information and the logical flaw. So I think we need to use inoculation theory on inoculations to promote hesitancy. Stefan, yeah, go Julie.
I was just going to add, I think I completely agree with what's been said so far. And I think the only other piece I would add, if you are someone who wants to engage on social media, there's a new organization, might be too strong of a word, and I think Dr. Brewer, you've mentioned this as well in some of your articles. It's called Shot Heard Round the World. And it's been, it was created by, I believe, 2 pediatricians in the United States, and has been very effective at sort of countering social media attacks on healthcare providers or others who are supporting immunization. And so I think that would be a way to sort of lend your support on social media that wouldn't put you out maybe in the field of fire so directly, but could also really counteract some of the activity that happens on social media.
And we'll hear from Todd Wolin, who developed the Shots Heard Around the World. He's part of one of these panelists as part of this program.
I want to maybe wrap up in a few minutes with 2 interlocked questions around COVID vaccination and seasonal flu vaccination. But let me just first give each panelist an opportunity, if there's an awesome question in the Q&A that you are just dying to answer. I want to make sure you have a chance to do that.
Yeah, there's a lot here.
I know there's a lot, and it's hard to talk and watch, but I didn't know if anyone had spotted one they were particularly keen. Absolutely fine if not. We can keep curating them and throwing them your way without your having to read over the top of your glasses. No. Well, let me these 2 questions around flu vaccination came in one after the other, and they're sort of flip sides of the same coin. So one is, should we consider tailoring our fall flu vaccination programs to some way anticipate that COVID vaccine might be coming? Is there anything different we need to do there? The flip side, can we take advantage of the fact that there will likely be interest in the COVID-19 vaccine to actually promote flu vaccine? Is there a way to get a boost on our flu vaccine coverage because people are already sort of eager and anticipating a COVID-19 vaccine?
I can start. Yes. Yes.
Yes, all those things.
Yes, I mean, I'm viewing the fall influenza vaccine as a trial run for COVID vaccines. It's going to be given to a very similar population who's going to need the COVID-19 vaccine. We're going to need to figure out sort of social distancing, because that's going to have to be in place for COVID. We'll need to have it in place for influenza. All of the sort of logistical issues around delivery of the COVID vaccine, we can trial with the flu vaccine. And I think a lot of the communication we can use as well. And we would be very smart to start talking about it in those campaigns. It's a great opportunity for some one-on-one communication, as long as we have enough information to be able to educate people. And that's the one piece I don't know that we're going to be far enough along in knowing what the vaccines look like to be able to have those conversations by the fall.
Julie, can I just ask a follow-up? Do you see with your flu vaccine programs more of the hesitancy and motivation challenges, or more of the sort of logistics, hassle, procrastination, behavior change challenges?
Oh, it's both. And we don't do a good job of teasing out how much it is of each. And another piece of the problem is that the flu vaccine is not universally covered in Canada in all of the provinces and territories. So that further complicates trying to measure what's driving it. But it's a bit of both, I would say, for Canada.
One of the things we have to figure out is how to get vaccination back on track. We have done a pretty good job with childhood doses, ages 0 to 6, for the most part, getting them back on track. Adolescent vaccines are still lagging by quite a lot. Adult vaccination, I'm not seeing good data on, but my impression is it's also down substantially. So I would like us to think about the fall seasonal flu vaccine as being a chance to get us all back on track. And what I mean by that in particular is, how can we get parents and families to understand that their healthcare provider is a safe place? The healthcare provider has their health in mind, and that going there is going to be a safe experience because they're going to have someone who's thought through when they'll be in their car or their public transport, how they're going to be in the waiting room, whether they're going to be in the office, who's wearing personal protective gear, and all of that. One of the things that I've noticed is that my pediatrician is great, but he hasn't done a great job of communicating about what they're doing. My grocery store has told me every last thing. I get a monthly update from them. I know how often they wipe down the milk case. I mean, I know so much detail about what they're doing. We need to do the same. We need to help providers communicate with their patients and their families about why it's safe to get vaccines from them. That's going to be a really important thing to establish, because if they're not feeling safe about getting a flu vaccine, it's still going to be a bit of a hurdle for getting COVID vaccine delivered. I also will say that there's a comment in here. Someone's doing some work in Uganda and about hesitancy, and I am happy to answer your question by email. It might be a little complicated to get here, but essentially there is this gap between intention and behavior that can be exacerbated when things are unavailable for some people and not others, and that can actually create interesting research questions. For example, examining the gap between intentions and behavior.
And how the perception of the availability of the vaccine might influence motivation, right, which I think will be very relevant with COVID. Any other thoughts at this sort of COVID seasonal flu intersection?
I've been, sorry, go ahead, Stefan.
Don't worry, go ahead.
For many years, you know, working on improving flu vaccination in children and adults for a long time. And my hope is that, you know, given that societies, governments seem to, if we have a good vaccine, people will be pretty motivated to have that vaccine because it will represent a ticket back to life as we knew it. And I know there will be obvious resistance. So if we can figure out really good ways of getting adults vaccinated against COVID, maybe, just maybe, we'll fix our flu vaccination coverage problem in adults, which is terrible. It's terrible in Australia, it's terrible in most countries. And we need to fix it because having, you know, even 50% protection in an older adult is better than no protection at all. So that's definitely one to watch. I hope COVID fixes flu vaccination.
Optimistic.
I wanted to go one step further than that, and just to bring to people's attention that in, well, most of the world, and particularly in those parts of the world where COVID has caused most havoc so far, we don't even have a flu vaccination program. And that's been very difficult to establish and has long been on WHO's agenda to establish, well, flu vaccination or more generally adult vaccination programs in Africa, for example. And I think indeed COVID may be a very useful, well, trial mechanism to, well, if we manage to use COVID in order to establish a mechanism that can be used in the long term to establish and improve adult vaccination, I think that would be good. But it requires some upfront thinking of how we can leverage that COVID vaccine and those delivery mechanisms for them to be set up in a way that, well, maybe then benefit in the long term as well.
I think that's a great segue to what I'm guessing will be our last question given the time, which is a question about what policy interventions we think will be helpful in promoting vaccine coverage. In your answers, I think it would be helpful for the audience to say what you mean by a policy intervention around vaccine, because that can take lots of different shapes. But thoughts on the policy side?
Well, I'll start. For federal governments, there probably are not, there are a lot of policies that they can enact that make sure that vaccination systems are well supported financially and structurally. But often mandates are perceived as the major policy levers for federal or state governments. And mandates can work. I think there's an article in the New England Journal of Medicine reflecting on COVID vaccine mandates and when that may or may not be appropriate. I've forgotten the first author, but Saad Omer is one of the authors. So that's one. But I actually think also, and again, I'm reflecting on the experience in Australia where we had a national registry for vaccination of children, which was extended to adults. And if you can get providers to use it well, so that every time an adult has a vaccine, it's logged into the national registry or the state-based registry, you can have really good data quality on whether the person's had their 1 or 2 vaccines or none, so that the provider knows whether the person sitting in front of them is vaccinated or not, and they have a mechanism for reminding them. So, you know, registries, a policy around registries and around multifactorial programs to improve coverage, including good support for providers, and maybe even incentives for providers potentially. Maybe some of the policy levers. I'd be interested to hear what the others think.
I would say there are 4 things that I would advocate for. One is that it's completely free. There are no copays of any sort. Even a small copay is a disincentive for people to act. The second is we need to make the settings that people go to completely safe. It can't be one of these things where people are in a queue, you know, all shoulder to shoulder. That's just not going to work. We need it to be a place where it's transparently safe, that people know going in that they're going to be okay and not get COVID going and getting a COVID vaccine. The next thing, obviously, is availability. We just don't know who it's going to be available for us and how, but we need to explain that in a clear way so that people aren't confused thinking that it's not available when indeed it might be available for them. And then finally, we got to make this easy. This has to be as easy as possible. Going through your existing provider is the most straightforward way to do this, but we've also heard in earlier conversations yesterday that it may overwhelm primary care capacity to handle all of these vaccines for an entire country. But for example, maybe pediatric care goes through pediatricians, and then maybe for adults, there are a couple of different options that are explored. So I would say definitely free, safe, available, and easy. Pull off all 4 of those things, as the CDC has done very, very well for many decades. I think that's the way that we can continue with this, making sure that we build on the existing infrastructure that is so effective.
And you know, that spells safe, Noel.
Oh,
like your 4 things. Yeah. If you just flip it around a little bit, you just created a great acronym. And to be clear, you were talking about COVID-19 vaccine policies,
yep.
But I think a lot of those might apply to the full program as well. Julie, I think you were going to jump in. Julie B.
Yeah, I was, but I would say I would just agree with the 2 comments that we've already heard. And I really like the idea of, you know, not just looking at these policy levers such as mandating it. I mean, certainly that's a very blunt instrument. It will work for a lot, but it's also going to have some backlash attached to it. But I think some of these other things that we've talked about in terms of strengthening our immunization systems, in particular providing compensation for providers to adequately deliver the vaccines, is an important one. We need them on board to have this be successful. It's going to be critical, and I think we could do a lot in those areas before we even have to go to something such as a mandatory vaccine.
The policy toolbox is big. Stefan, let me just turn it back to you for any last comment on the policy side. It was your comment about some places don't even have flu vaccine programs that maybe want to do the policy question. So,
actually, I don't think I have anything to add. There's some excellent responses there.
Can I just point out that if it really is true that we're talking about mandates, I really encourage people to read the lovely article by Julie and Saad and Cornelia Betch on under what conditions do we require vaccines. And there are a few things that we really need to get in place, including availability and so on, to ensure that there's equity. We can't just decide we're going to twist the arm of the whole nation. There are some people who would be inclined toward doing that. It's a very bad idea. I think it could be disastrous for vaccination in the U.S. to go in guns blazing without first setting up the right infrastructure.
I will throw the link to that paper in the chat for everybody while we wrap up. Let me thank Doctors Flasha, Brewer, Leask, and Bettinger for this really, really robust conversation about so many aspects of vaccine hesitancy, and hand the baton back to Matt for our day 2 wrap up.